In this video, we will cover the topic UTI. By UTI, I mean urinary tract infection. We will start our topic with a clinical scenario and will solve the scenario at the end of the video with key points related to USMLE and PLAB. My video will include the following parts: introduction and classification, risk factors, clinical features of UTI, organisms involved in UTI, diagnostic tests performed, treatment, and in the end some USMLE and PLAB key points. So first of all, the scenario. Read the scenario for 2 minutes and we will solve this scenario at the end of the lecture. I would recommend to take a screenshot of this video so that we can continue our remaining lecture. So now we will start with the classification of UTI. Our first classification is on the basis of anatomy. It includes upper UTI and lower UTI. By upper UTI, I mean kidneys and ureter, and by lower UTI, I mean bladder and urethra. Then the second type of classification, it's based on severity of the disease. Uncomplicated UTIs and complicated UTIs. Mostly the non-pregnant ladies and postmenopausal women, these are classified in uncomplicated UTI. Complicated UTI, by complicated UTI we mean the UTIs which are associated with the following risk factors: diabetes, immunocompromised patients, pregnancy, renal failure, serious anatomical malformations, catheter associated UTIs, hospital associated UTIs. After that, we will classify the UTI on the basis of clinical symptoms. By clinical symptoms, we mean asymptomatic bacteria and symptomatic bacteria. Those patients who have positive bacteria in urine but they lack the symptoms of UTI, they are classified as asymptomatic bacteria. But those patients who have bacteria in their blood, in their urine, and as well as they also have the symptoms of UTI, these are classified as symptomatic bacteria. We will learn the symptoms, we will learn the clinical features in the coming slides. So now coming towards the risk factors. The risk factors of UTI are on multiple bases. These can be anatomical, these can be infectious. So the first one, anatomical causes, that is urinary bladder diverticulum, neurogenic bladder, urinary tract stones, benign prostatic hyperplasia BPH, urinary system malformations. After that, it's the sex. By sex we mean females mostly, because the female have a shorter urethra which provide a short ascent to the urinary tract, to the kidneys, to the bladder, to the ureters. Thus females are mostly prone to urinary tract infections. Secondly, the uncircumcised males also come in the category. It's also one of the risk factor for UTI. Pregnant ladies, because there are hormonal changes in pregnancy which cause urinary stresses and thus UTI. Immunocompromised patients, previous UTI history, urinary catheters, and postmenopausal women. After that, we will come toward the clinical features of UTI. The clinical features of UTI are differentiated by lower urinary tract infections clinical features as well as upper urinary tract. In the lower urinary tract, we have the clinical features like increased urinary frequency, dysuria or painful micturition, hematuria, suprapubic pain, and urinary urgency. The upper UTI, in upper UTI, patient will have the symptoms of lower UTI as well as some systemic symptoms like fever, costovertebral angle tenderness on physical examination, nausea, vomiting, as well as flank pain. It's not necessary that the patient will have all of these features at the same time. There can be relapse, there can be some symptoms which appear in the beginning and later on the other symptoms can appear. Common organisms involved in UTI, we will discuss them as bacteria, viruses, and fungi. So in bacteria, the most common organisms is E. coli. Second most common organism in sexually active women is Staphylococcus saprophyticus. First one is still E. coli. Third one is Klebsiella pneumonia, Proteus mirabilis. The Proteus mirabilis is, there is an association of this bacteria with struvite kidney stones because it's a urease producing bacteria. It makes the urine alkaline, which provides an optimum environment for the formation of struvite kidney stones. So whenever there is a patient who has struvite kidney stones on imaging, you should have an idea, you should think about Proteus mirabilis. After that, hospital-acquired bacteria, which include Pseudomonas and Enterococci, Enterobacter species, Urea plasma urticulum. In viruses mostly cause, mostly or almost in all of the patients, they cause UTI in immunocompromised patients, like patients going through chemotherapy or transplant patients. And the viruses in this category are adenovirus, PK virus, CMV virus. And CMV virus is associated, there is an association of this virus with hemorrhagic cystitis. There is another drug which also causes hemorrhagic cystitis, and that is cyclophosphamide. You should remember it because it will help you in your exams. After that, we come towards fungi. Most common is Candida. After that, Blastomyces, Dermatitis, Cryptococcus neoformans. So now coming towards diagnostic tests performed. The diagnostic test performed, the first one is urine analysis. In this, what we see pyuria, the presence of WBCs in urine. Leukocyte esterase, it's an enzyme produced by WBCs. So if the leukocyte esterase is produced, it means there is pus in the urine, it means there is infection of UTI. And how many WBCs should be present? Equal to or greater than 5 WBCs per high flow, per high power field, or 8 to 10 WBCs per mmQ. Bacteria, it indicates positive nitrites, and nitrites are produced by gram-negative bacteria. So if the urine test is positive for nitrite, it means the gram-negative bacteria are present in the urine, and it's a sign of urinary tract infection. Sometimes you can also have an idea of infection by pH. If they suppose, as I already mentioned, that Proteus mirabilis, it makes the urine alkaline. So if the pH is raised, if the pH is A, suppose, so it means that pH is alkaline, and you should have an idea. You should think about urease producing bacteria. Sometimes we do urine culture, but it is not indicated in all type of UTI. It's indicated in selected patients, and indications for urine culture are complicated UTI, pyelonephritis, urosepsis, and recurrent UTI. Sexually transmitted infections also are one of the indications for urine culture. Thirdly, we can also perform imaging tests for UTI. And indications for imaging are suspected UTI due to obstruction, renal abscess, UTI not responding to appropriate treatment, early recurrent UTIs. What sort of imaging will be performed? We'll perform CT scan as well as ultrasound. CT scan with or without contrast, ultrasound KOB. So one point which you should remember is that we perform CT scan with contrast as well as without contrast. With contrast is performed in patients if there are complications related to like abscess, or suppose there is pyelonephritis and the patient is having an abscess, then we will perform CT scan with contrast. And if the UTI is most likely due to some sort of obstruction, then we will use CT scan without contrast. So the last one is treatment. We will discuss the treatment of UTI according to the type of UTI. So the first one is for urethritis. We can use ceftriaxone intramuscular plus azithromycin per oral. For cystitis, there will be the treatment will depend on whether it is complicated or uncomplicated. In uncomplicated cystitis, we can use TMP, SMX, trimethoprim, and sulfamethoxazole, nitrofurantoin, and fosfomycin. For complicated cystitis, we will use ciprofloxacin, TMP, SMX, and ceftriaxone. The third one is pyelonephritis. So the treatment of pyelonephritis will depend whether the patient is outpatient or inpatient. In outpatient, we will use ciprofloxacin, and in inpatient, we will use ceftriaxone and as well as aminoglycosides, for example, gentamicin. If abscess is present, then we should do drainage, and as well as you should use antibiotics. And we can also take the culture of the abscess to target the specific organism that the bacteria is sensitive to which sort of antibiotic, and then it can be treated much better. The fourth one is catheter associated UTIs. The first step which you will do is the removal of catheter, and then urology consultation should be done. We can also use urine culture in catheter associated UTIs, because most of the catheter associated infections could be caused by antibiotic and by bacteria which could be resistant to multiple antibiotics. So empiric therapy should be continued, and then culture specific therapy should be started. The fifth one is recurrent UTI. It's most commonly it occurs in women, and by recurrent UTI we mean 3 or greater than 3 episodes in 1 year, or 2 or greater than 2 episodes in 6 months. Its management includes antibiotic prophylaxis as well as behavior modifications. In antibiotic prophylaxis, there is the first type is continuous prophylaxis, and the second type is intermittent prophylaxis. In continuous prophylaxis, we use TMP, SMX, or trimethoprim alone. We can also use cephalexin and nitrofurantoin. In intermittent prophylaxis, it is mostly associated with recurrent urinary tract infections associated with sexual activity. The antibiotics used are trimethoprim, sulfamethoxazole, cephalexin, as well as nitrofurantoin. And the behavioral modifications, it's also very important in management of recurrent UTI. It includes increased fluid intake so that the bacteria should be flushed out of in the urine. It includes post-coital voiding, and in post-menopausal women, we can also use topical estrogen, which will help in the prevention of recurrent UTI. So in the end, we will solve the scenario. As you have already read the scenario, so we will come towards the answer. So in this scenario, what the patient is having the typical symptoms of urinary tract, as I already mentioned in the clinical features, like suprapubic pain, mild burning with urination, and the urine analysis shows WBCs of 26. We read that 5 or greater than 5 WBCs per high power field, it indicates infection. So the patient is have their labs as well as the symptoms correlate with a urinary tract infection. So which of the following is the most likely cause of this patient diagnosis? And that is A, ascending infection, because in women there is a shorter urethra, and bacteria ascend through that urethra, and then it can cause urethritis, it can cause cystitis, and most likely this patient has urethritis, as the patient is having suprapubic pain and mild burning. There are no symptoms of upper urinary tract infection. The patient is having a lower urinary tract infection. So finally, at the end we will discuss some exam points related to USMLE and PLAB. So one thing which you should remember, that they sometimes they rarely ask direct questions like diagnosis or risk factors, or which type of bacteria is involved, but most commonly they will ask you a secondary or tertiary level questions. For example, they will give you a scenario of patient having sign and symptom of UTI, and they will ask what will be the best initial step. So some will go for CT scan, some will go for urine culture, but in the first test which you will perform, as I already mentioned, is urine RE. So you will go with urine RE. They can also ask about diagnostic test for UTI due to possible obstruction, but they don't know. But there will be a possibility that there could be stones, there could be some stricture. So what will be the best diagnostic step, investigation or test for detecting stones? It will be CT scan. They can also ask you tricked about the UTI, whether for example, they will mention like what is the most common cause of UTI in sexually active women, and there will be both options of E. coli as well as Staphylococcus saprophyticus. But you should remember, as I already mentioned, that E. coli is the most common, though Staphylococcus saprophyticus is also common, but it is the second most common cause. The first one is still E. coli. Sometimes you can be tricked by such questions, but you should remember that E. coli is the most common. So these are some exam tips, and we will discuss in our coming videos about, because UTI is not alone simple topic. It's a complicated one. It's have multiple relations with different sorts of infection, different sorts of malformations, and then UTI is also most common in pregnancy. So we will, in the coming lectures, we will discuss what sort of complications could UTI cause in pregnancy and immunocompromised patients, and there I will also give you some exam tips, and this topic will be covered more elaborately. Thank you.